Anyways, for those of you that don't know me, my name is Karp, and I'm one of the third-year emergency medicine residents. The topic of my grand rounds today is goals of care in the emergency department. I want to start off by talking about my inspiration. There we go. My inspiration for this talk. So this article came out in the New Yorker a couple of months ago called The Hidden Harms of CPR. In it, Dr. Sunita Priya, a palliative care doctor, talks about how it's an open secret in medicine that CPR is both brutal and rarely effective, yet how the public seems woefully aware of this reality. Case in point, this article was initially sent to me by my mother, a non-medical person, who sent it to me saying, "Do you know this?" When I told her that I did, she rightfully said, "Well, that's pretty messed up." And in the article, Dr. Priya talks about difficult goals of care conversations she's had and how her failure to accurately depict the reality of CPR have led to codes that are familiar to all of us. The slow code, where everyone walks over to the patient at a leisurely pace. The fast code, where only a round or two of CPR are performed. And the code that is so brutal and inhumane that you feel sick. Reading this article, I reflected on my own experience discussing goals of care in the emergency department. So I want you all to imagine a case. It's an evening shift at the evening shift at the general, and you're working in OBS. It's busy but bed blocked. Offload is full, and CT is taking 4 hours. It's one of those general OBS shifts that makes you question all of your life choices up to this point. A patient comes in, he's 85 years old, and he's coming in with a COPD exacerbation. He looks unwell, but not resus or emergent unwell. You mostly just notice that he looks frail. A scan of his chart that shows that he has COPD on HOMO2 and lung cancer on second-line treatment. And although he looks frail, he still lives at home with his wife. He's there today with his daughter, and you go and explain to him that he's going to require admission to hospital. I want you all to think for a second. Is this patient you would discuss code status with? I saw this patient at the beginning of R2, and partially because it was a busy OBS shift, but mostly because I didn't know if I should say anything, or really what I would say. I didn't say anything at all. I didn't discuss code status. I didn't discuss what he would want if things got worse. Instead, I called medical oncology and continued with my shift. Well, things did get worse. A few hours later, the med-onc resident came and told me that the patient was in respiratory distress and asked us to help with intubation. After we intubated him, he arrested. And after 20 minutes of rib cracking and blood spurting CPR, he died a violent death. What struck me most about his family's reaction was not how upset they were. Of course, I was expecting that, but how absolutely shocked they were that something like this could have happened. And I remember thinking, there's no way that anyone would have chosen to die like this. So everything that went wrong in that scenario is the basis for my grand rounds talk. Decoding code status, conversations that matter in the emergency department. The goal of this grand rounds is to do better than I did, to be better at these difficult conversations in the difficult space that we work in. It's to provide a framework for shared decision-making conversations around goals of care that bridge the gap between what patients know about themselves and their values and what we know about resuscitation. First, I want to talk about the public's perception of CPR and resuscitation methods and contrast that with the open secret in medicine about the reality of these therapies. I then want to convince you of something I've learned and reflected upon since that OBS shift, which is that emergency room physicians should be the ones having these conversations. And lastly, and most importantly, I want to provide you with a framework for these conversations, and not just the easy conversations on the ward or in the ICU that can take place over a few days, but the fast and critical conversation in the emergency department, and the conversation where you disagree with the patient and the legal implications of that. So first of all, as we'll talk about, the public is heavily influenced by CPR that they see on TV. So let's see what we're up against. I decided to ask a few people in my life what they knew about CPR. This is my partner, Shane. He's 33 years old and he's a master's student. We've lived together for 7 years, the duration of my medical career. And I often explain to him about my work woes. Let's see how much he listens.
How often do people live after CPR?
I didn't realize that CPR could someone could die from receiving CPR if that's the case.
So when do you think people get CPR?
When they're unconscious.
Like when they pass out or something?
Yeah.
Okay.
This is my dad. He's 69. He's a retired investigative journalist for CBC. He's had 2 open heart surgeries, pacemaker, 3 strokes. He also has epilepsy and pulmonary fibrosis. None of his doctors have ever spoken to him about goals of care.
How often do you think it happens that there's a good outcome?
I'm just thinking about it. This, I will say approximately 40% of the time, people regain consciousness. And, you know, I don't know how long it might take, whether it takes a day or a week or, you know, a couple of weeks, people will be back to normal.
This is Nana. She's 84. She's a retired farmer. She's had 2 heart attacks and is about to have a carotid endarterectomy. None of her doctors have ever spoken to her about goals of care.
How often do you think it works?
Oh, Jesus, I don't know. Oh, don't put that down. I would hope 9 out of 10 times anyway.
Yeah.
Mm-hmm.
And what about if people need CPR while they're in the hospital?
Well, I would hope it would work. You know, I would hope it would help 100%. Maybe not always, but if you're right there to do it, I would think it would, you know, would kick in.
I promise you, it's not just my family. On average, the public believes success rates of CPR are 59% in hospital and anywhere between 40 and 60% out of hospital, depending which study you look at. Research has shown that this is heavily influenced by television, where on average, patients survive CPR 69% of the time. Being trained in CPR or having friends or family who are in medicine did not influence the public's perception on the effectiveness of CPR, which I guess explains my family. So we know they're wrong, but how wrong are they? Locally here at TOH, survival to hospital discharge of in-hospital cardiac arrest is 25%. For out-of-hospital cardiac arrest in Canada, the rates of survival to hospital discharge are between 3.9 and 7.1%. But that's just survival to hospital discharge. A study out of the US in 2020 that included 187,000 victims of in-hospital cardiac arrest showed that survival at 1 year was 9.4%. And as we all know, rates are negatively influenced by conditions like frailty, terminal illness, and progressive organ failure. Of course, this is just survival, and neurologic sequelae following cardiac arrest is high. Studies quote rates of disability, specifically a modified Rankin scale of greater than 3, in patients who survive in-hospital cardiac arrest, ranging from 30 to 40%. So now we know there's this huge gap between what patients believe about CPR and what we know to be true. And we have to find a way to bridge this gap. And no one's ever really told us how to bridge this gap. The results of the survey that you all filled out show that very few of us received any feedback on our own goals of care conversations during medical school and residency. And that lack of direct feedback has effects. More than half of us are only somewhat comfortable or are not comfortable having these important conversations. This was also reflected done in a study by our very own Dr. Steve Sanders et al. That showed only 4 out of 17 emergency medicine residents interviewed had had any formal education on how to have post-status conversations. And residents often felt insufficiently prepared for these discussions. But despite the lack of training and our relative discomfort around goals of care, these are conversations that we're having all the time. 25% of us are having these conversations weekly, and another 50% are having them a few times a month. So this is something that we do all the time. And even though we don't feel very comfortable doing it, it makes sense that we don't feel comfortable. It's a pretty tall order to convince your patient that you're not as good of a doctor as the doctors on Grey's Anatomy. Let's see. Okay, so there's this gap, and we have to find a way to build or bridge the gap. But no one's really taught us how to bridge the gap, and most of us are somewhat uncomfortable building or bridging the gap. But I really want to convince you that it's all of us who should be bridging the gap. And the reason is threefold. disposition, moral injury, and because we have no other choice. So first of all, in the words of Dr. Choi, medical patients die on surgical wards and surgical patients die on medical wards. The disposition of patients is our responsibility. Studies have shown that 75% of patients will visit an emergency department within the 6 months before death. And then initiating a palliative care consult from the ED shortens hospital stay by an average of 4 days and results in fewer deaths in hospital. This represents a huge potential for intervention. We have the power as ED physicians to alter the trajectory of these patients' admissions. But more importantly, a multi-center prospective study across 12 acute care hospitals in Canada showed that 88% of older adults admitted to hospital with serious illness prefer a less aggressive and more comfort-oriented end-of-life care plan that does not include CPR. However, this was only documented in 30% of their charts. By having these conversations early in the ED, we have the potential to not just alter their admission trajectory, but also impact the way these patients live and die. The second reason relates to moral injury. Moral injury, as we've all heard many times since COVID-19, is when we feel we've violated our conscious or moral compass by taking part in, witnessing, or failing to prevent an act that disobeys our own moral values or personal principles. To explain this, I want to go back to the story of my bad code. After I ran the code on a patient who I knew had no chance of improving, subjecting him to a violent death, I thought and ruminated about that death afterwards. Even though this was an elderly man with end-stage organ failure and cancer, I couldn't get his last moments out of my head. And I think most of us have stories like that, where we've run a code and we've known that it won't work. The reason why this feels so wrong is because we have a duty to provide patients with treatment that is in their benefit. In fact, we took an oath saying we would do exactly that. This goes back to the pillars of medical ethics, non-maleficence and beneficence. And we incur moral injury in these cases because we know, even if our patients don't know, that in many cases, in most cases, CPR is not just of no benefit to them, but actually results in harm. And finally, as our population ages, access to primary care diminishes, and bed blocking worsens, it is more likely that the patient codes get harmed. So like it or not, it's our conversation to have. Fortunately, I think we, as emergency room physicians, are expert communicators. One of the reasons I went into emergency medicine is because I was impressed by ED docs' unique communication skills. Their ability to rapidly synthesize unorganized information into a differential, to reassure a benign chest pain, and to break bad news minutes after meeting a patient. So even if the family doctor or oncologist hasn't had this conversation, we should feel empowered to have these discussions and not just shrug it off to the Valoncar one who's been up all night. Because it's our clinical obligation to correctly disposition the patient. It will be our moral injury to bear if we don't. And I think we have the potential to be excellent at it. And it probably doesn't take as long as you think. Unfortunately, I couldn't find any eMERGE specific data, but on average, for an oncologist to perform a high quality face-to-face goals of care conversation, it takes 15 minutes, which actually feels like maybe a long time for the emergency department, but in comparison to running a code, it definitely isn't. And I also think that's probably a pretty significant overestimation for the ED. We'll touch on some ways later to enhance your efficiency by expressing urgency. But just as a reminder, you can also build a K code for this discussion. So now that we know it's our responsibility to have these conversations, let's look again one last time at what we're up against. So minutes after awaking, he solves a medical mystery. But again, there's this gap. We need to bridge it. We should be the ones bridging it, even though no one taught us how. With bed blocking, lack of primary care, and an aging population, we will increasingly be the ones required to have these conversations. And although there's quite a bit of literature on how to have these conversations, there's little literature that's specific to the emergency department. In fact, a systematic review published in Emergency Medicine Australia in 2019, looking at primary evidence of goals of care conversations in the ED, found that there was no evidence for how ED conversations differed from those in other settings. Fortunately, there's an abundance of literature on goals of care conversations in general, and many expert opinions on how to apply these models to the emergency department. So after going through the literature and participating in many online modules, as well as speaking with experts, this is what I've come up with. This model is based primarily on 3 different sources. The first is from Annals of Emergency Medicine, created by ED and palliative care physicians that focuses primarily on the communication aspect of things. And one from Healthcare Quarterly, created by physicians at U of T, London Health Sciences, and Western University, that focuses on fulfilling your legal and ethical obligation, as well as documentation. The last source I use is the expert opinion of Dr. Gianni D'Egidio, who's one of the physicians who linked me the Healthcare Quarterly article. This model is an amalgamation of their work. So step 1, review the chart. This part is key. You want to understand their illness and treatments. See if you can find an advanced care conversation documented in the chart. You should become a medical expert on your patient. It's a good idea here to also look for any objective indicators of end organ damage, like ejection fraction, PFTs, MOCA scores, as well as the opinion of other outpatient care providers, if you're able to find them. Step 2, express urgency and assess understanding. This is when you first sit down with the patient or their loved one. You want to explain the severity of the situation while at the same time gleaning insight into their understanding of things. By opening with urgency here, you signal to the family that this is a time-sensitive discussion. Step 3, determine capacity and determine substitute decision maker. Unfortunately, we don't have time in this grand rounds to go over capacity determination, but in the ED in times of critical illness, it's often the SDM we're having this conversation with because the patient is regularly too sick to partake. Step 4, ask for permission, then signpost. The asking for permission part always felt kind of awkward and clunky to me, but it's referenced in so many different sources. And the reason is because in times of an out of control scenario like this, it allows the patient or loved one to regain some control. The signposting here is also critical. You want to be sure that you're adequately expressing the severity of the situation. Step 5, ask about an advanced care plan. This step is crucial in determining if the patient has previously expressed wishes and often gives you an idea of how the rest of the conversation might go. Step 6, align yourself as a team and explain both roles. In this step, it's important to use language like we statements to frame yourself as a team with the patient or their SDM. The essential part of this step here, though, explaining roles, was emphasized to me by Dr. D'Egidio. Dr. D'Egidio pointed out that we often don't accurately explain the role of the substitute decision maker. When we fail to do this, it centers the SDM in the conversation rather than the patient, and it forces the responsibility and the weight of these decisions on the SDM. Often, this is when loved ones feel like they are the ones who have to make a decision about pulling the plug. Instead, the role of the substitute decision maker is to act on prior expressed wishes, or to act in the best interest of the patient. And by explaining this to them, we alleviate some of that burden. Step 7, assess values, goals, and wishes. This is the point of the conversation where you provide a few leading questions and then allow the patient or their loved one to speak. Primarily here, you should be listening and allowing for silence. Silence can be awkward, but a good rule of thumb is that when there is silence, only speak again if you're asked a question, if they speak, or if they look at you. Step 8, summarize. Summary is key to ensure you're both on the same page before moving on to the next, and most important. Step 9, share a recommendation. Here you want to provide a recommendation and relate it back to their case. The primary focus here should be highlighting what you will do. In all patients, it's a good idea to express that you'll treat their pain and make them comfortable, and then tailor the rest to your specific scenario, whether that includes fluids, antibiotics, or full resuscitation. But importantly, you have to tell the patient and document in the chart what therapies will not be provided. Before I speak more about that, about withholding resuscitative treatments, I want to talk about the importance of providing a recommendation in general. I believe that we should be providing a recommendation in all cases, even when the family sees eye to eye with you, or if they have a good understanding of how infrequently CPR works. And the reason is the same as why it's important to explain goals, because it lessens the burden of the family. Goals of care discussion should never be a menu of decision options, but rather a partnership between clinicians and patients, where the result is a treatment that's in the patient's best interest. In a move away from paternalism in medicine, providing a recommendation has, at times, been criticized as playing God. But I strongly disagree with that, because we're not making decisions about who lives and who dies. What we're doing is using our medical expertise to make decisions about what therapies we know work and which ones don't. By using this model of shared decision-making, the patient or loved one acts as an expert in their values and wishes, and you act as an expert in medicine, and together you make the decision. And I think this is well highlighted in a commentary written by Dr. Uchi, who's a Harvard palliative care and ED doc and the author of the Annals of Emergency Medicine model I referenced earlier. He had the experience of having his father have a massive stroke unexpectedly. He sat down to have a goals of care conversation with the intensivist, and upon sitting down, the doctor said to him, "Would your dad want a trach and peg tube at age 70? Dr. Uchi said that although he is a physician with expertise in this area, he had no idea how to answer this question as the son of his only father. By engaging in shared decision-making, Dr. Uchi writes, we also share the burden of the responsibility of this decision. And again, this also highlights the importance. Okay, now let's talk about withholding resuscitation. The legislation in Ontario was recently changed to allow physicians to refuse or withhold life-saving treatment. This followed a medical malpractice suit that came to the Ontario Superior Court of Justice in 2019, known as Wawrzyniak versus Livingston. Elizabeth Wawrzyniak is the daughter of Douglas Daguerre, an 88-year-old, very comorbid man who was admitted to Sunnybrook ICU after bilateral above-knee amputation secondary to a gangrenous infection. He survived his short ICU stay postoperatively, but then developed delirium, necrosis over his surgical sites, and cardiovascular instability. His physicians, Dr. Livingston and Dr. Chapman, an ICU and internal medicine doctor respectively, noted his decline and made a decision that CPR would not benefit him, and wrote an order in his chart to this effect. They attempted to call his daughter to let her know, but she was unavailable. Later that evening, his daughter showed up to the hospital and noted him to be in respiratory distress. She called her father's medical team over to help, who began providing breaths. But when Dr. Chapman arrived, he requested the team to stop and explained that further resuscitation was of no benefit. Mr. Daguerre died a short time later, while his daughter, who was a nurse, attempted to resuscitate him by herself. Mrs. Wawrzyniak then filed a $2.2 million lawsuit for negligence and malpractice against Dr. Chapman and Dr. Livingston. The case reached the Ontario Superior Court of Justice in 2019, where the allegations were dismissed. The judge ultimately ruled that a physician's decision to withhold resuscitative measures is not treatment, and therefore does not require the patient or their substitute decision maker's consent. So, just like you don't need consent to withhold a transfusion for a hemoglobin of 100, or withhold a norepi drip for a MAP of 80, you don't need consent to withhold resuscitative measures, be it fluid, antibiotics, CPR, or intubation, if you determine it would be of no benefit. The CPSO also recently updated their policy to reflect that. The bullet point version of the policy is that when the risk of harm associated with resuscitation outweighs the benefits, resuscitation can be withheld. Before making this decision, you should consider the values and the wishes of the patient, and you should, again, emphasize what care will be provided. You should make every attempt to tell the patient or their substitute decision maker about this decision before you write it in their chart. But if things are critical, you can inform the substitute decision maker afterwards. You don't have to wait. If you follow the framework that I presented earlier, you'll fulfill all of this criteria. But what if that doesn't work? What if you have an angry family member or patient who doesn't agree with you? The CPSO says that the physician can still order to withhold resuscitative measures, but you have to continue to support the patient or substitute decision maker by, again, clarifying any misunderstanding, emphasize the treatment you will provide, and offer multidisciplinary social support, as well as facilitating a second opinion. On that note, I asked Dr. Degidio about disagreements, and he highlighted how the ICU is a huge resource here. Call up to the ICU physician and ask for support and a second opinion. In fact, he said these are some of the best calls he can receive. He also said that whenever there's a time pressure, it's important to go back to the basics and look at objective measures, like end-stage organ failure or other comorbidities, and ask yourself if there's any options left for treatment. Also, a new service we have here at TOH that Dr. Degidio informed me of was the ACP team, which is an effort spearheaded by Dr. Degidio and Dr. Hartwig. The team is still in its infancy, but it's already up and running. And it's a team that can be consulted from anywhere in the hospital, including the emergency department, between the hours of 9 to 5, Monday to Friday, to help with difficult ACP conversations. To conclude now, I would like to redo my goals of care conversation with that patient at the beginning of part 2.
Hi, thanks very much for taking the time to sit down with me. I'm Dr. Karp. I'm the resident taking care of Mr. Peters today. Do you mind telling me your name and your relationship to him?
Hi, my name's Angela and I'm his daughter.
Okay, thanks, Angela. I really wish we had met under different circumstances. Your dad is very sick, and I think it's important that we act quickly. What's your understanding about what happened today?
Well, I'm not really sure. His breathing wasn't doing too well over the past couple days, and I know that you said that his chest x-ray doesn't look great. Maybe he has another one of those COPD exacerbations.
Yeah, you're right. That is what's going on. And as you know, he also has this metastatic lung cancer, which is complicating things and making him very frail. Since your dad seems pretty confused right now and he's working hard to breathe, I'd like to speak to a substitute decision maker about what we're going to do going forward. Do you know who that would be?
Yes, it's me.
Okay. Okay, so unfortunately, I'm afraid I have some bad news. May I share it with you?
Of course.
So your dad's very sick. I'm very worried about his breathing, and I'm worried that things might worsen quickly, and it's even possible that he could die.
I don't really understand how this could happen so quickly.
Yeah, I'm very sorry that we're in this position, but together we can work quickly and find the best path forward. Does your dad have any living will or any sort of written plan of what he would want in this situation?
No, he doesn't really have anything formally written or documented.
Okay. And have you and your dad ever talked about what he would want if things were to worsen?
Not really. We were just trying to be hopeful and positive, but I know that he did mention he was really afraid of dying.
Okay, yeah, I'm sorry. That's all very normal. Oftentimes people have not thought about this. Since that's the case here, I want to explain how this works and what both of our roles are, and then together we can work together as a team to find the best path forward. So your job as his substitute decision maker is to express the values of your dad, his wishes and his goals, and to make decisions that are in his best interests. My role as the doctor is to provide medical care and therapies that align with those goals. And together we'll come up with a plan that is in his best interests and work forward. How does that sound?
That sounds okay.
Okay, so first of all, can you tell me about your dad? What does he do these days in his free time?
Well, to be honest, he's been so exhausted lately, he doesn't do much. He does have the television and a couple TV shows that he likes watching, and he has dinner with my mom often, and he does visit with his grandkids a lot.
Okay, and how have he and your mom been managing at home?
Honestly, not great. Her health has not been the best either, and when one of them gets sick, they really struggle, and it seems almost impossible for them to stay in their home. My brother and I have been trying to convince him that it's time to go into a nursing home or a retirement home, but he's been refusing. He's just a really proud man.
Okay, I'm sorry, that sounds very difficult to manage. How do you think your dad would feel if he were to get so sick that he wasn't able to return home or care for himself as much as he does?
So like I said, he's just such a proud man. He's always said that he would never go into a nursing home or it would be over his dead body. But as I said, he has mentioned a couple times that he's really scared of leaving my mom alone as well.
Okay. And is there anything else he told you he was afraid of?
I know that he's really afraid of dying or having pain in his last moments or feeling like he's suffocating. And that's because this one time with one of his exacerbation, he had a lot of difficulty breathing and it really, really freaked him out.
Okay. So what I've heard from you is that your dad really valued his independence and that he would not want treatments that left him dependent on care or in a nursing home. Is that right?
Yes.
Okay. So if that's the case, based on what you've shared, the plan going forward will be this. We'll provide him with treatment with the goal of getting his breathing to a comfortable state. We'll give him antibiotics and fluids to treat the infection, and we'll give him puffers to help with his breathing, and we'll definitely make sure to control any pain he has. If he does get sicker and stops breathing, or if his heart stops, things like CPR and intubation will do much more harm than good, because they won't change the fact that he has cancer and COPD, and they will very likely result in a quality of life that would not be acceptable to your dad. So it's not something that we'll offer at this point. Instead, if that were to happen, we'll focus on his comfort and dignity and making sure that his family are nearby in his last moments.
Okay, that's really hard to hear, but I understand, and I do think that it's probably what he would want at this point.
Okay. Thanks very much, Angela, for sitting down with me. Do you have any other questions?
I don't think so right now. Thank you, Dr. Karp, for your time.
Okay, so of course, all conversations are not going to be as easy as between me and my voice actor, Cam. But I'm standing here right now. I don't feel like this is something that I've yet mastered, and I'm not sure if I ever will. There's many ways to have this conversation. And like intubation, central lines, and chest tubes, these conversations involve micro skills that need to be tuned with time and practice. But my hope is that every one of us feels empowered to have these conversations. If we do, and even if we don't do it perfectly, our patients will be better off, our department and hospital will be better off, and we will be better off. Ultimately, I believe that engaging in these conversations will lead to increased job satisfaction, improved outcomes, and less burnout. I'd like to say a huge thanks to Dr. Syed for his immeasurable guidance throughout my first grand rounds, as well as to Dr. DeGidio and Dr. Viancourt for the data. Next, I'd like to say thanks to my family, especially Shane, who deserves at least 50% of this, but also my dad and Shane's grandma. And then for the entire R3 cohort for your support, but especially to my voice actor, Dr. Dajanane. Thanks, guys.